Hi, everybody. Happy Tuesday. Today we are so grateful to have Dr. Beighley here from Department of Health. And we have made him a co-host. So when his slides are ready, he is going to speak to us about medical conditions manifesting as mental health problems. So thank you, Dr. Beighley.
My pleasure. So how is this looking for you? Are you seeing the slide? Okay.
Perfect. Three
All
shades
right.
of blue.
Beautiful. Yeah, so as was mentioned, I'm at Mauna Kea today with the eruption. All of a sudden, all our friends and family have a desire to come visit us this week. So we went up to see the eruption, and I'm at Mauna Kea looking out at the beach as I speak. So forgive me if the hotel internet has any glitches. So far, it's been pretty good. So what I'm going to talk with you all about today is medical conditions manifesting as mental health problems. And I'm with the Hawaii Department of Health. I'm the medical director for Adult Mental Health Division on here in the Big Island. And in doing this presentation, I have no actual or potential conflicts of interest in relationship to this presentation. So when I first started working on this, I had in my mind I was going to go over a bunch of presentations. Maybe somebody comes to see you, they look like they have major depression, but then it turns out they have thyroid disease, or they have TB infection in their spinal cord, meningitis, or something like that. And I started doing a literature review and started to think about what I wanted to talk with you all about on this subject. And I found there were a bunch of rabbit holes that came up. A rabbit hole means that you find kind of a little bit of a area that's tangential to it and worth exploring and thinking about, but you could really get caught up in going down these different paths. So I'm going to try not to do that, but I do think that we should talk about a couple of things before I go into what you all might be here and expecting, which is the lists of diagnoses and how do we know if it's a DSM-5 major depression or thyroid disease, for example. And so I'm going to talk with you all about the idea of a functional versus an organic diagnosis and what that means and how that influences us in treating folks in psychiatry. I'm going to talk a little bit about the medical model, and then I'm going to talk about the biopsychosocial model, which is really what we use in psychiatry rather than a straight medical model. And then after I do that, I'll go more into what you all might be expecting, which is the lists of some specific diagnoses that you all might see and how they may actually be medical conditions versus a DSM-5 condition. All right, so let's first talk about this idea of a person who comes in to see you with a collection of symptoms, and is that a organic or a functional disease or process? So I'm going to assume that if somebody comes to see me, they're asking for my help to treat a set of symptoms or problems. And one way we approach this as physicians is to think about this as being a functional versus organic disease. You learn about this very early on in medical school, and it's not something that's necessarily taught to you, but it's something that you recognize as being a valuable way of conceptualizing when somebody comes in with a set of problems, to kind of categorize it in this way. An organic disease means that there's a health condition, it's got a observable and measurable disease process, like inflammation, tissue damage, that there's a validated and qualified standardized biological measures, and we call these biomarkers. So if somebody comes into the emergency room and they have a set of symptoms, and you can see that on vital signs they have an elevated temperature, and you can do a blood test and see their white count is up, and then you go to the source of pain and you do a blood culture or a culture, and there's a bacteria there. These are all really good evidence that there is normal physical process, that now there's a disease process that's caused by a recognizable organic cause. So we call folks that come in for treatment who have that kind of constellation where you could find a physical cause. Another example would be somebody with pain in their legs. The leg is deformed. You do an X-ray and there's a fracture. That would be classified as an organic disease. Whereas a functional disease means somebody comes in perhaps to the emergency room again. They have a set of symptoms. The blood tests are done, the CT scans, the X-rays are done, the physical exam is performed, the vital signs are performed, and none of these has any actual findings that is that's outside the normal range that you might see on these tests. And those conditions would then be classified as being a functional presentation or a functional process. And if you think about this, you may immediately have objections to classifying a process or a presentation as functional or organic. And I'm going to absolutely agree with your objections in advance without even hearing them. It's very imprecise. And yet, this way of conceptualizing and thinking about symptom processes persists because it just is a useful way of approaching problems that we are presented with and trying to help people, this functional versus organic disease. One of the objections might be that there almost is an implication that if it is a disease of the function of an organ system or an organism, that somehow that implies that it's not real, that we can't find an organic basis means there is none. And that's not true at all. An example would be epilepsy or seizures. It used to be that epilepsy, was classified as a functional disease because before having EEGs and CT scans, we may not be able to see any evidence of actual organic illness other than the presentation of the person with the seizures. And people can come into the emergency room with seizure-like behavior and have an EEG, electroencephalogram, that's normal, in which case we might call it a pseudo-seizure rather than a traditional seizure, now that we have a basis of knowledge of what seizures are that are caused by abnormal electrical activity in the brain. Migraine headaches in the past have been classified as functional, and we now have some good theoretical basis to understand what's causing them organically, even though we may still lack some of the biomarkers we would like. Alzheimer's dementia also might have been classified as being a functional illness. Now you can do biopsies of brain tissue and see changes, but you wouldn't want to do that on somebody who's alive for the most part. So again, there is a blurring. And who's to say, for example, that schizophrenia, which is diagnosed based upon a set of symptoms, is not caused by some underlying abnormality of the normal human process of brain interaction, nerve cell interactions in the brain, neuron interactions, that we just haven't been able to really establish yet. I mean, we do know that certain types of medications working on the dopaminergic symptoms seem to alleviate symptoms of schizophrenia, but we really just, again, don't have the level of biomarkers that would move that particular constellation of symptoms and that disease diagnosis into the realm of being organic yet. Hopefully that would happen at some point. That's a wonderful thing when we can actually have biomarkers to help us with diagnosis and establish if treatment is successful. But again, functional versus organic disease, psychiatrists and folks in the mental health field, we tend to see folks who present with diagnoses that would fall into the functional category. And if you look at DSM-5 and you read how we diagnose folks, in large part it's based upon, not based on a blood test or a scan, but based upon a presentation of a set of symptoms. There's some exceptions. For example, intoxication with alcohol, you would be able to draw a blood alcohol level and see. But a lot of our diagnosis, mood disorders, anxiety disorders, thought disorders, really there's no biomarker that would fall in the functional category. And so we conceptualize and think about how to best help folks with these classifications of disease in the best, or disorder the best way that we can. That's not to say that functional disorders are solely in the domain of psychiatry or neurology. Irritable bowel syndrome, chronic fatigue syndrome, fibromyalgia, TMJ pain, gastroesophageal reflux disorder, interstitial cystitis. These also might be thought of as being functional disease categories. But again, DSM-5, you look at DSM-5 and it really kind of meets that way of conceptualizing conditions as being functional rather than based upon an underlying organic cause that you can find. So that's one concept I wanted to talk about, because when we get to the lists towards the end of the chat, really what's going to come down to is if somebody comes in to see you and they have a problem, you're trying to sort out, is this a functional diagnosis that fits into the DSM-5 way of looking at, or psychiatric or mental health way of looking at problems? Or is this something that falls into an organic cause that you're really going to focus on treating with organic or somatic treatments? I'm going to shift gears now and talk about the medical model. And as I said, we're going to get back to the idea of functional versus organic in a little while. But let's talk about the medical model now of treating patients or people, consumers, clients who come in to see you with a set of problems. Now, when I say medical model and I hear the term medical model, what comes to mind is almost a pejorative use of the term that implies that doctors treat patients as organic processes rather than human beings, that the doctors or the psychiatrists are pushing pills. Um, it's become almost pejorative. In the disability scholars particularly might say that the use of the medical model that treats folks with physical disabilities or who have been classified that really reduces them to the level of a medical problem rather than as a human being, where you want to look at the societal implications of the limitations they might have physically, or that the limitations are really a result of society not being cognizant and working to help accommodate, like we accommodate for so many normal conditions to let people get around and to work and to do things. So the term medical model immediately brings to mind criticism. I think it's also maybe used as a way of kind of attacking psychiatry. Psychiatrists just want to prescribe a pill. But I think the medical model is more than this, and it should be more than this. In psychiatry, we want to recognize that we do have medical treatments as psychiatrists, as physicians, that may not be available to others who are working in the mental health field. And I think it's very important as a psychiatrist that I need to know when I don't want to prescribe a medication. I think the most important work that I do as a psychiatrist is when I don't prescribe a medication, than when I might prescribe a medication and to see if it helps or not. And that's recognizing that just because a person has a diagnosis or a set of symptoms doesn't mean that you automatically need to reach for the prescription pad. A lot of the medications, somatic treatments that we have cause problems worse than they may actually help with. You may well have somebody who has lived with schizophrenia for many years. Their family and friends have accommodated that, and to try to treat them with an antipsychotic in hopes it might reduce some symptoms that are mildly impacting their life, but then give them weight gain, metabolic syndrome, and lower their lifespan, it may not be a reasonable thing to do. So I think in psychiatry, we hopefully are not, as psychiatrists, just looking at medical only. We're trying to do more than that. And we also want to recognize the autonomy of people to make their own decisions. We also want to recognize there are a lot of variations of normal in how human beings act and interact with others and express themselves and experience being a human being. So in psychiatry, really, over the last, 50, 60 years, and certainly in my residency training years ago, more than I would like to admit, and in current training programs, the model used in psychiatry is not really a medical model. It's more what's called a biopsychosocial model of health. And I'm going to kind of show you how that works in practice in a moment. So in the biopsychosocial model of health that psychiatrists should be trained in, we're going to think about human beings that come to us with a problem is not just having a biological cause, an organic cause, or a cause that we want to use somatic treatments to address, but also having social issues where their interaction with others in their environment impacts the presentation, impacts their experience of the problem they're bringing in for us to help them with, school, occupation, family relationships, a past history of trauma. Psychological considerations are also very important to think about. And the mental health is a confluence of all these things, not just biological, but also social and psychological. And we want to be more sophisticated in how we treat people than to figure out, hey, is there a medical problem that's masquerading? Because again, there are a lot of gray areas. So I'm going to give you an example in just a minute as to how we want to think about folks when they come in to see us, and why this biopsychosocial model is really pretty useful and really kind of the standard for which psychiatrists should be looking at. Now, I'm also going to admit to you that the way that insurance companies reimburse, the way that healthcare organizations want to use psychiatrists, does constrain us to being focused on the biological aspects of treatment. But it's not because necessarily it's our training or inclination to do so. There are other factors and forces that are involved in which of these domains that we look at when we treat patients, but we should be looking at all of them and thinking about all of them. So let me give you a real life example. So as the medical director, I sit on treatment team meetings that we have where the psychiatrist who's treating a patient, the case manager who's helping the person, the nurse that's at the clinic, and others, maybe the substance abuse specialist, would talk about the case when there's a problem and we want to try to help the person, and they seem to require a little bit of extra effort because of a problem that's presenting outside of what we might expect. And how can we use our different domains, the biological, psychological, and social, to help that person? And this is very much a real life example. So I was attending one of these treatment team meetings, and the case manager said there was a concern at a group home about a 70-year-old male. This is a person, he had a diagnosis of schizophrenia for many, many, many years. He'd been with us as a patient for a long time. He'd been doing pretty well at this group home. His symptoms had been relatively stable in terms of auditory hallucinations and delusional thinking, but he was being withdrawn. He wasn't interacting with others in the group home setting. He wasn't participating in activities. Friendships were suffering. He seemed like something was different. Something had changed in his ability to enjoy life, and what was going on here? How could we approach helping him with these symptoms, these problems, that would be thoughtful and not just let's try increasing his antipsychotic medication because maybe the psychosis is worse. Maybe we should try him on an antidepressant. Maybe we're seeing some depression. Instead, let's use this biopsychosocial model and talk about what might be going on to try to understand what's happening here. So what's the biological approach? Well, the nurse did a review of systems. Was something new going on physically? Had we missed something? Was he taking his medications? Had he stopped taking his medications? Was there a value in looking at new medications or changing medications been on for years? What were the risks in doing that? Did we want to just do a trial to see what would happen? Social, the case manager was speaking with the group home manager, talking about what was going on with how he was interacting. Was he having a conflict with other folks in the group home? Was he withdrawing because he didn't want to have that conflict? Or they had new members come into the group home that might have been difficult for him to relate with or to deal with? Was there change in the management of the group home? I mean, just looking at that social setting and how that might be impacting why he was presenting the way he was. But also looking at how his withdrawal was impacting his ability to have friendships and to enjoy life in that social setting that's so important to us as human beings. And then psychologically, how is his self-esteem being impacted? Was there some depression? Was something going on where he was grieving a loss and he was withdrawn? Was he having difficulty expressing his needs for some reason? Was there a psychological cause? So we wanted to put all these things together to address how to help this person. We weren't using a quote medical model to change medicines or try a new medicine. We're using a biopsychosocial model that included looking at biological factors and medical factors and trying to put together in a holistic fashion what's going on and how can we help this person who's under our care and part of our community to figure out what had changed, what happened. We evaluated the patient, we looked at all these factors, and it turned out that the problem was over time, his foot care was not doing well. It's ingrown toenails. It basically hurt him to get up and walk around. Nobody had really examined his feet to see what was going on. He had difficulty articulating and expressing himself that this was a problem. And once we identified that this was what was changing over time, and we got podiatry care in and cleaned that up and helped with that hygiene, he was back to his previous baseline level of functioning, is getting up and moving around, getting exercise, interact with folks. So this was a physical problem manifesting as possibly a DSM-5 diagnosis, worsening of the schizophrenia or mood disorder. And we found it out by using a model of looking at the whole person and looking at different possibilities and how these different possibilities might even interact with one another. So to me, this was actually a profound thing that we did to help, was to identify in all these possible things that were going on, what was necessary to try to address. And cutting the nails, addressing these foot issues had a profound impact on the quality of this person's life. So it seems maybe kind of a simple thing, but it was really profound in this person's ability to enjoy life, interact with others, and function. So it is important, I think, that we look at people in a holistic, complex way. And if there are medical problems that are impacting the presentation, It may have nothing to do with the psychiatric illness, but can interplay with it. So this is, again, a way to think about and conceptualize medical problems and presentation. All right.
We did have a question before you gave us the answer, Dr.
Okay.
Weir asked if there are any changes in tremors, but I'm assuming no.
Well, see, I think this is a good question. We could go down a long list of possibilities here, right? I mean, there's so many things that could cause the presentation of decreased interaction with others. And so what we had to do was to really have a very broad net. And we did do a review of systems with the nurse member of the team that looked at changes in physical symptoms. And we did vital signs, had those changed. We looked at recent medical problems, had they changed? We looked at the medication that had changed. It took some time. It was involved a team. And it, again, used this idea of a biopsychosocial approach where you cast your net widely and don't just jump to an assumption that the problem is going to relate to a single diagnosis that you've been following or a medication.
And he also asked, how often do patients in this situation have full physical exams done?
So we try to make sure that they have annual follow-up with their primary care doctor. You know, there is some controversy about doing annual physical exams. It used to be thought everybody should get an annual physical exam. There's been some literature to suggest that's not the case. It's really based upon the age of the person, comorbid physical problems. So I think we really try to address it case by case, but we do try to have that integrated care where we reach out and work with a primary care doctor. And if we notice a problem that seems to be in another medical domain, we do use the case manager to try to help, and the nurse and the doctor try to reach out and to bridge that and to get them in to see the primary care doctor. Another good example of that is we know that antipsychotic medication use can correlate with metabolic syndrome, and that can cause elevated blood sugars, blood pressure problems, and that can lead to additional problems. So we monitor some of these parameters, lipid levels in the blood, on our folks that are on antipsychotics. And if we catch this through our screening, then we refer them on to be seen by primary care to address that, and also look at, you know, are there alternatives to the psychiatric medication, somatic treatments that help mitigate that? It's a problem.
You know, it's also interesting that I've heard the nurses tell me they don't do the medical model. They treat patients in a nursing model, which is separate from the medical model, which surprises me because I thought it was all under the medical model, but no, nursing does things differently.
Well, I think that's one of the points I'm trying to make too. As a psychiatrist, I'm not using the medical model. I'm using a biopsychosocial model, which is, you know, arguably a type of medical model because it incorporates it. So I think the idea that psychiatrists or mental health providers with psychiatric background are simply using a medical model, it's not accurate for many of us, and it's unsophisticated. Really, we're not just trying to use a pill for every problem. If we're doing our job properly, we should be thinking in a more complex manner. So let's talk about now what you all probably thought this talk was going to be about from the beginning, which is some specific diagnoses and presentations. So there's an adage in medical school and residency, and that adage is, when you hear hoofbeats, think horse, not zebra. So if you hear hoofbeats off in the distance, think horse, not zebra. What does this mean? What it's really saying is, don't find a remote and unlikely explanation for something you hear or see without first looking at the most likely cause. So if you're out hiking and you hear some hoofbeats, it's probably not a zebra galloping around in a neighboring field. It's probably a horse. So look for the most obvious before you go for something that's unusual. We don't want to rule, that's not to say we don't want to rule out zebra diagnoses, unusual diagnoses, because they can have catastrophic consequences if you don't identify them. And it might be that some folks will say the organic diseases are less likely to be than the functional diagnosis in folks that we see, but you really do want to think about zebras, but not let them predominate your thinking as you do an evaluation or follow-up. Let me give you, again, kind of a more concrete example of the zebra versus horse way of looking at the world. So a person comes in to see me, and they're saying they're having problems because they get anxious, and their blood pressure goes up, they get headaches, they get sweaty, their heartbeat goes up, they may have some tremulousness, and they get pale, short of breath, and then it clears up. And it clears up, they're not anxious anymore, their vital signs are normal. And then all of a sudden, out of nowhere, boom, they have these symptoms come up. So in this case, what might be the horse and what might be the zebra? Well, there's a condition called pheochromocytoma. I think this is one of the medical students' favorite diagnoses, because who can't like pheochromocytoma as a diagnosis, right? And pheochromocytoma is a very rare tumor. It's usually benign in and of itself. It's on the adrenal gland. And what it does is it can dump out adrenaline from time to time. So pheochromocytoma can present exactly as I just described. But in fact, pheochromocytoma cases are pretty rare, like 8 per million people. Whereas anxiety attacks, panic disorder, can experience very much the same way I just described. Each year, up to 11% of Americans will have a panic attack, and with 2 to 3% of them, one study I looked at, going on to develop a panic disorder. So that's the horse, right? But here's the thing: with pheochromocytoma, you can actually treat it, cure it surgically. And if you don't identify it and treat it, you can go on to have some really bad complications, including death. But to diagnose pheochromocytoma, you have to do a 24-hour urine test and hope during that time you get one of those periods where the tumor dumps out the adrenaline. So it's complicated, expensive to diagnose. So it's important to find the zebras. But on the other hand, if we treated every person that came into us with panic attacks as having pheochromocytoma doing that workup, it would be a very low yield, but an important one, but have consequences. So this is kind of a way of thinking about when somebody comes in to see you and they have a set of symptoms. How do you prioritize your diagnoses, and how are you going to work them up, or how are you going to try to help them? In that way, to me, my approach is, regardless of the specific symptoms or problems somebody comes to me, I don't fall back to the list that I'm going to share with you in a minute, but instead I look for red flags in the presentation that clue me that what I'm seeing is not a functional diagnosis, but an organic one, going back to that original concept we talked about. Because if there's an organic disease process, it's probably going to be able to be treated and addressed differently than I would treat a DSM-5 functional diagnosis. If it's an organic diagnosis, it's going to be a biomarker. There's going to be a well-described physical organic lesion or problem, metabolic problem, that can be addressed medically. That's not going to be treated symptomatically, as we do with most of the medications that we have in psychiatry. So this is something I want to spend a little time sharing with you, because if you see any of these red flags, it may give you pause that this is a zebra and not a horse, that what you're seeing may be falling outside the normal presentation of the conditions that we treat in mental health. At my point in career, I also will tell you that my intuition plays a part, because I've seen so many patients over the years who have symptoms that are similar to one another and that follow into the DSM-5 way of conceptualizing mental health problems. If somebody sees me and they have all the symptoms to meet a DSM-5 diagnosis, but there's something about 1 or 2 of the symptoms, or there's some additional information that is not in keeping with what I've seen over many, many cases, that to me is going to make me pause and think, maybe this is the one zebra that I'm seeing that I would otherwise not see, and need to spend the extra money and time doing additional testing or additional follow-up. So what are red flags in general that might clue you that this is a zebra? It's got an organic basis and not a functional one. First is onset. So we know that a lot of the DSM-5 diagnoses that we follow have patterns of onset. For example, we know in schizophrenia, the onset tends to be with prodrome in late teens, early 20s. So if I have somebody who comes to see me and they have all the symptoms that are schizophrenia, but it started at age 40 suddenly, then I'm probably going to think this may not be schizophrenia because it's not following into the pattern I would normally expect, even though the symptoms are the same based upon the sudden onset and the age. If there are medical problems and the person has complex medical history, that also is going to make me have some pause, and I want to look at whether or not I'm seeing a manifestation of one of the other medical problems that have been diagnosed that may be looking like a DSM-5 functional psychiatric diagnosis. If there are physical symptoms, for example, a pain in a defined part of the body, or vital sign abnormalities, these are going to make me think, okay, I'm now seeing maybe a biomarker. I'm seeing some organic basis, something that I can track and look at. Intermittent or waxing and waning symptoms can be a clue too. I mean, we know some of the diseases that some of the conditions that we follow have a characteristic pattern where they really do not have quick changing, waxing and waning. So if we see the onset or the improvement, exacerbation or worsening or improvement of the symptoms in a way that's not characteristic that we normally see, that might be a clue. Vital signs and world vital signs are significant. Although again, if somebody's having a panic attack, you could see elevated vital signs that would be normal during a panic attack. Abnormal lab values always are going to have, if there's significant abnormalities, you need to establish why they're abnormal if you come across them. An atypical presentation, as I mentioned, for intuition is saying something is different about this presentation than what I've seen in the past. If you are over 40 with no past psychiatric history, something I would think about. So older age, no past history established of the DSM-5 diagnosis. Now, some DSM-5 diagnoses are more likely to occur at older age, but this is something that adds to my index of clinical suspicion. If you treat somebody with a medication and the response they get to the medication is unusual, or they don't get a response that you might expect for a benefit, or they get worsening, that might make me think I'm seeing something different than what I thought I was seeing. Collateral history can be very important. Sometimes people cannot give us a history that indicates that there's additional problems, and we need to talk to family members or friends. The classic example of this would be somebody with sleep apnea. So you have a person who comes in to see you, a 50-year-old overweight person, and they're noticing that in the mornings they're very fatigued and their concentration is poor, and they feel maybe they have depression. And then you ask their partner, hey, does your wife or husband snore at night? And they will say, oh my gosh, not only do they snore, but the whole bed shakes. And sometimes they gasp and they stop breathing at night. In which case, okay, this sounds like sleep apnea. We've got to rule out that as a cause. I've had a number of cases where that turned out to be the problem. I sent the person to a sleep lab. They found out there was sleep apnea. They put them on a CPAP machine. Their brain's got enough oxygen at night, and suddenly their daytime symptoms vanish. So collateral history can be important.
We just had a couple talks about sleep apnea, and the person might be thin and you might not even suspect it, and it turns up that it's the cause of their depression and other things. So very interesting that you bring up.
Absolutely. You can have different types. There's obstructive sleep apnea, but there can also be sleep apnea that's not related to obstruction as well. But this would be a clue to me, because sleep apnea in somebody who's not obese, who's younger, who the partner's not giving the history, then I'm starting to get into zebra territory. And I'm not going to send everybody who comes to see me with depression for a sleep study. If I did that, it would be problematic and probably not necessary. So how do I know when to send the person for a sleep study? Well, one would be to get that collateral history and to look for some of these other red flags. But yeah, it could be that I would miss some zebras by doing this, and this is of concern. But if I put the person on antidepressants, I followed them for a while, they weren't getting better, or maybe they're getting worse, then maybe that would be the clue for me to start looking for, again, more of the zebras in that kind of case. Speech deficits, if a person is slurring speech, missing words, that would be of concern to me, of some neurologic process going on that might not be classified as strictly functional. Motor symptoms would be very high concern. Olfactory hallucinations would be of concern, of a seizure disorder, for example. We know that usually the hallucinations we see in our patients are auditory. If somebody's having visual hallucinations, that makes me think maybe I'm seeing something other than functional. And headaches. There are other things that could come up on this list of red flags. I just wanted to put some things down that I have seen and think about as maybe being in zebra territory. But I'm sure there are others that we could find. All right, so now we're going to get to some of the lists, maybe where the money is for some of you who came to the talk today.
Can I give you a quick example that one of our participants gave us?
Sure.
So Claire saw a patient who had her makeup on really kind of sloppily applied, and she was worried that, maybe there's a symptom of mania, but she asked when the woman had last had her eye exam, and she hadn't. And so the next time she saw the woman, she sent her for optometry, and next time the makeup was applied perfectly and she was wearing glasses. So very interesting, where she thought it could have been a psychiatric diagnosis, but it was definitely an organic thing that she could fix with an eye exam. So that's a great example.
It's really interesting. I mean, you can see, we could go down a lot of different examples. You could see, for example, somebody who comes in to see you where they have neglect on one half of the body, but not the other half of the body in terms of dress or hygiene. And that could be indication of a hemispheric problem. There's so many of these, but I think the point is, and this is very important, that there's something about these cases that are not in keeping with other cases we've seen in our professional career. There's something about it that's different, and it makes you question. And sometimes it's a hard time to put your finger on it, but you might say, this person's speech patterns are different than what I might see. Or, yeah, the person has pressured speech, or they have, characteristic speech we see with clanging or other, findings, but there's also some slurring of speech here that's significant. So sometimes it's a little bit difficult to articulate, but when we find these subtle things that put the person in a little bit different category, we should listen to our own clinical judgment, our own clinical experience, and say, okay, this is the person that we want to spend a little bit more resources on, more energy on, and evaluating and looking for that zebra. What are some of the most common things? The less zebra azebras. What are some of the medical problems that are not rare and that we do see in mental health field? Well, delirium is one, very common. Delirium is related to a metabolic problem, usually, could be infectious as well, and it waxing and waning. The person gets confused on and off. Frequently in older folks, you will see them have visual hallucinations, again, not auditory, but visual hallucinations. So delirium is a common thing that we see that is an organic. You can track down what the underlying cause is. As a psychiatrist, when I work in hospital settings or have worked in hospital settings, frequently I would get a consult request from one of the docs, maybe a surgeon, maybe another specialty that has somebody hospitalized. And they would say, I have this patient and now they're hallucinating and they have fluctuations in their mental status. Is this a psychiatric problem or something else going on? I think we've got somebody who's needs to keep put on. Thanks. So one of the things I would evaluate is I would go in, I would call the medications, their vital signs, the labs, maybe order some new labs to establish if this was a psychiatric, a functional problem or delirium. Another typical example, you have an older person, they've started hallucinating, and it turns out they have a urinary tract infection. Okay, you could treat that, and then the delirium might clear up. Dementia is another common concern. Somebody who's a bit older, perhaps, or you can have aggressive dementias that at a younger age can look like depression, where a person has impoverished thinking and speech, withdrawal. So, we want to look for the patterns that suggest dementia as a problem rather than depression. Seizures can be strange because not all seizures involve the whole body. Seizures can involve just part of the body or can involve a person having lapses in consciousness. So partial complex seizures can be extremely strange in how they present. So seizure disorders we think about. A traumatic brain injury, I think we've had more and more awareness of this. If somebody who's had a history of closed head trauma or repeated traumatic brain injuries in sports, that can have a really profound effect. I think of Muhammad Ali, the great boxer, and through all those repeated bouts of head trauma, what the result was in terms of his neurologic status. But we've seen, less florid examples of that. We see that all the time. Infectious, we see in infectious processes changes in how a person thinks and behaves. The brain's very sensitive. to infections. Even now, long COVID, we can see these changes in how a person is feeling and doing. Metabolic, these would be conditions, perhaps electrolytes, potassium or sodium is not at normal levels. Could also be blood sugar is not a normal level. And really, unfortunately, common in Hawaii, methamphetamine intoxication or intoxication supplements. Cannabis also can certainly cause changes in appearance. So these are some of the most common concerns that we have. I wouldn't call them zebras exactly because they're pretty common overall. But these are things that I think about when I'm doing an assessment or doing follow-up. Other common concerns, delirium tremens, alcohol withdrawal. And in fact, alcohol withdrawal, DTs, can be fatal and very profound. And you're not going to know about it necessarily from the person. You might have to get collateral history, as we spoke about. Strokes and brain bleeds can have, again, acute presentation. I mentioned that as being a red flag. And also people who are post-stroke may be more prone to having depression. Multiple sclerosis. This can be one that has waxing and waning of symptoms because where the area of the brain is that's being affected by the MS may change over time. So again, what's the red flag? The waxing and waning and the variation in symptoms over time. Korsakoff syndrome, which is related to chronic alcohol use and the lack of certain vitamins. You can get severe memory problems from this and other symptoms, which can be treated if you catch it early and successfully and prevent tremendous long-term devastating consequences. Abnormal blood sugar, again, it may well be somebody's on insulin or blood sugar lowering medicine and their blood sugar is too low, it can be fatal, but you can treat it pretty quickly if you catch it. Or too high of blood sugar can present with changes in mental status and intoxication, of course. So these are things I would think about at the back of my head in folks that come to see me as possible causes of symptoms. Let's talk about now psychosis, depression, and mania. And we should wrap up with a few minutes for a case if you all want to talk about one. Psychosis is, as we all know, altered mental status reality testing, frequently presents with delusional beliefs, maybe paranoid beliefs, and frequently auditory hallucinations. But that also can be similar to what you see in a delirium state, where there's an alteration in a metabolism or an infectious etiology or cause, or perhaps brain tumors, for example, structural illnesses. So again, psychosis is one that we want to look at if it's atypical presentation. It's not going along as we think it should with a schizophrenia diagnosis or a mood diagnosis or mania diagnosis with bipolar. So that's one we want to look at very carefully. Depression, some things we think about. First of all, there's a kind of a reverse situation where the person is diagnosed as having depression. In fact, they have, they're diagnosed as having dementia when in fact they have depression. So it's called pseudodementia. And you can see elderly folks who have significant depression and they're misdiagnosed. They actually have depression that makes them psychomotorically slowed and having problems with cognition and concentration. Thyroid disease is something we can easily look at with a thyroid test. And if it's present, it can look like depression. Cancer can cause weight loss, loss of appetite, and other symptoms that look like depression. And apnea, we talked about, is one that is not uncommonly seen and can look like depression and have neurovegetative symptoms that we see in depression. And then mania, of course, intoxication, particularly with methamphetamines. Thyroid, it can cause depression if it's too low. If it's too high, you can get manic symptoms. And again, people with significant delirium from a number of medical causes can have a presentation that looks manic. So that's kind of an overview. I think the most important thing, rather than memorizing specific diagnoses, is to have an index of suspicion that's triggered when you see a presentation that's outside of the normal range. So I'd be glad to open up for questions or a case if you all would like.
Does anybody have a case today or a follow-up from a past case? Remember, you get $150 good for spending for Christmas. Questions? So I was looking up the difference between the medical model and the nursing model. Does anybody want to talk about that? So let's see, the nursing model, which nurse practitioners follow, is based on nursing theory. That's a framework that defines what nurses do and and why they do it. And it guides nursing practice, includes nursing process, which provides the step nurses take to care for patients, the steps. Assessment, diagnosis, plan, implementation, and evaluation, which is different, of course, from subjective, objective assessment and plan. So it's kind of interesting.
I'd like to comment.
Yeah, go ahead.
I think what the confusion is with nursing is I've got 3 degrees in nursing, and my first 2-year degree, which also it could have been either hospital nursing or college nursing, was basically basic caretaking in the hospital setting. The 4-year degree was more into management, but my graduate degree was basically similar to the medical degree in psychiatry, even though we didn't ascribe to just one theory. We had, perhaps if I can recall correctly, about 9 or 10 different theories, everything from the holistic perspective to the more medical integrative model. And that's why I think there's so much confusion as to what nurses do, and because it's not understood. So I think nursing created that problem themselves by having the same title, nurse, and people are, oh, I didn't know you could do psychotherapy. Oh, I didn't know you could prescribe. I thought you were a nurse. So I have to go through the whole level of education. But I want to say maybe about 20 years ago, I was being reimbursed directly by the insurance companies. Initially, you had to live in a rural area, but I was living in Houston and they were reimbursing me, and that wasn't a problem. Today, insurance companies will not insurance companies, because I believe Medicare does, but people that are hiring will not acknowledge nursing. They will acknowledge social work. They will acknowledge LPCs, but they will not acknowledge the nurse, when actually the nurse is in a position to even identify what we were just talking about, iatrogenic illness and all that. So it's been like nursing has been skirted out of the way. I don't understand all the politics behind it, but I do know that there's a really lack of, I think there was a politician not long ago that said, well, nurses don't have any college education, and everybody, but she was saying what she believed. It wasn't like she was putting nursing down. That is what she believed. So it's very, very interesting, because I have spent the Department of Education in Hawaii. I sent an application and they said, oh, we see you have prescriptive authority, you have this, but you don't meet the minimum qualifications. And
Can I
can
I jump in and say a couple of things? First of all, in our model, which I think is a common one, community mental health, the role of the nurse is critical, and it's not duplicative as to what the psychiatrist or the case manager or other folks are doing. The nurse brings a unique perspective and value to helping the patient. So in the example I gave, it was the nurse who actually went out to the home, saw the patient, observed the patient or the consumer in the environment, did the review of symptoms, and helped coordinate the care with a podiatrist. That was all functions that in our system the nurse was able to do, and that role was crucial in that outcome. So I think nurses have different roles in different systems. RN.
Because yeah, but
we have APRNs.
I am APRN, which is different. I can diagnose as you can.
Yeah, I know. We have APRNs also in our system, so we have both. But in this particular example, that treatment team had the RN. We also have treatment teams where the APRN is running the team and has an RN working to do that part of it. So we do have our APRNs who are involved, and at doctorate level, by the way, involved in managing the treatment team.
Well, yeah, I understand what you're saying, but I can practice in Hawaii and Arizona independently and make psychiatric diagnoses. In other states, they're not able to make a diagnosis. So that's why there's so much confusion, because everybody does not understand, because nursing themselves have created three tiers that don't make any sense. You know, there should be like a beginning nurse, bedside. So it is very complicated. I speak about it passionately because there's a lot of nurses that have been ousted and have left the profession because they're still the society wants to force them to be an RN when they actually have advanced education and can treat clients, not only in psychiatry, in all these other disciplines, similar to a PA. In some states they can practice and have more independence, and in others, it's very limited. So I just wanted to clarify that, because it's a big passion of mine that nursing organizations unfortunately don't seem to be concerned in clarifying.
I do want to
was
thought.
concerned. Yeah, go ahead.
Yeah, I just want to also put out that every member of the team in that case that I brought up was very key to helping that person. And the case managers, to me, the case managers that we have in our system are the heroes. I mean, I think the docs are great, the nurses, the APRNs. I mean, we all do our part. But those case managers, particularly during COVID, who are going out there, who transport the patients in their vehicles, who are the consumers in their vehicles, who are so key in the well-being of these folks, really are part of the care, part of the biopsychosocial approach, and I find them to be tremendously valuable in helping our folks.
Yeah.
Sorry to cut you off there.
I agree. And Renata says, I think many people don't understand that disciplines can obtain doctorates and are not just medical doctors. Basically, we all have to work together, and a lot of people don't understand the different levels of training. And I have to say, nursing is extremely difficult because you've got 2-year RNs, 4-year RN, and everything in between. So I think the teamwork is what's so important. There's a good question here from Dr. Weir, who says he's always practiced in areas of physician shortage, such as the Big Island, and psychiatric patients are notoriously difficult patients for non-psychiatric physicians. Could you discuss just how do you ensure that your psychiatric patients get competent medical care and evaluation? There are often problems with sharing of information between psychiatrists and other medical professionals, and that makes it really hard.
Yeah, there's been a big push for what's called integrated care, where you have psychiatric care being provided at the same location or the same organization as other medical care, primary care specialties are practiced. Some of the federally qualified healthcare centers, have good interaction, shared medical records, and so forth, good ability to refer. If you're an independent practitioner, I think it's in the community, it's harder. AMHD, Adult Mental Health Division, with COVID, we had a hiring freeze. We had folks that we weren't hiring. We kind of suffered, I think, in our ability to have the staffing and the types of people that work in our teams to help make sure that would happen. In our system, I can only speak to our system, we have the RN nursing member of the team as really key in helping do the integrated care. We should have on an annual basis, all of our consumers, all of our patients. Sorry, I'm old. I'm going to call our folks patients because that's just where I come from. On an annual basis, to sit down, go through a review of systems, make sure all those medical issues that have been identified are being treated, to reconcile the medications between what we're prescribing, what we have on our lists. The other area of concern too that we have in Hawaii is that we don't want patients to get opiates from multiple different doctors or controlled substances from multiple different doctors. And there's a database that one can use, but it has to be tracked. So trying to integrate care across providers, when somebody has difficulty communicating their needs, they have limited socioeconomic means. These are all challenges. Again, we're fortunate at AMHD that we do have the teams with case managers that can help with that, the RNs, but it certainly is a challenge.
This is obviously a very heated topic that's why I usually avoid it, but because it came up today, I felt an obligation to speak up. And to your question about teamwork, I did a lot of volunteer with the VA and the active duty members, and had actually one of my clients that was hospitalized and diagnosed as schizophrenic at 42 years old, which I was horrified. I'm glad you brought that up today. And basically what had happened was that he was Asian, and they had been pumping him with all these medications, and he ended up just developing a pseudo schizophrenia. And sadly, he was discharged after 12 years of honorable service. So I feel really good that I was able to catch that up and reach out to people, but because I was a nurse, it was basically ignored, and he ended up being discharged. A very, very sad story. So I think we all have our strengths, and I think it's important that we listen to each other rather than feeling that our degree is the one that speaks loudly, because in my experience, that hasn't been the case. To me, it's taken humility to focus on the patient and not get involved in the politics. But today, I just felt this was the time to just express what I had been through.
Thank you for doing so, by the way. This, as I said, when I first started working on this presentation, you know, I can just give a list of diagnoses that look like schizophrenia but are not. But it is more complex than that, because it really goes to the heart of what is our role? How are we trying to philosophically approach helping, you know, somebody who comes to see us or that we're asked to care for? How do you conceptualize functional versus organic? There's a lot of complexity to this. So, you know, on the superficial level, okay, sleep apnea can look like depression. But when you start thinking about it a little bit deeper, yeah, it opens the door to a lot of discussions and maybe some difference of opinion.
Yeah, I think this is a really good discussion. And I will just point out that the humility that Sue mentioned really is important in this, because that is how we listen to other people. That is how we step back and anyway.
Can I let me riff on that one last? I'm sorry, I just have to say.
No, do it.
Humility also is in our own abilities to make a diagnosis. And if we have humility, we're able to say, my initial diagnostic impressions were mistaken because I now have more information. I'm not locked in looking at this as a particular diagnosis. I can obtain and listen to others. I can listen to another provider who may have a different set of degrees, but has more information to share. I can listen to family members. I can listen to the person themselves. I can listen. And I'm not so locked in on a certain way of thinking that now I'm not able to evolve and look for zebras or look for other causes than I originally thought. So I think this is also the hallmark of maturity in a medical provider or a mental health provider, is a willingness to reconsider early opinions and openness, self-humility to say, let's relook at this, or ask for a second opinion, or ask for another opinion in another domain or another specialty. That's so important.
And I think you just described cultural competency or cultural humility. So thank you. Next week, we have Dr. Ona talking to us again about the RTMS, the this trans cranial stimulation for what is the M?
Magnetic?
Magnetic.
Yes, magnetic.
Cranial magnetic stimulation. Okay. So you guys know what I'm talking about, but updates on how that's going. And I'm interested to hear if more insurances cover it, and if it's how the home stuff is going. And Renata said, oh, there's lots of thank yous in the chat. Renata says, if everyone looks at a ball in the same room, they see different parts of the ball, which may or may not look the same. So anyway, thank you very much. Wonderful presentation as always. And we'll see you next week, everybody.